another episode of Med School Mondays with Promo. Alright, if you were with us in the last lecture, you just learned about depressive disorders. Then I told you guys, go get some water, get some coffee, get a soda. Hopefully you didn't get the soda, but you know what I mean. I said take a break. So in case you're joining us for the first time, I suggest you put this video on pause. Check that video out first because this is a continuation lecture. Now that we're ready, let's get right to it. We want to talk about the medications that help to treat depressive disorders. We're going to see some other uses of them as well. We want to start off with the SSRIs, the selective serotonin reuptake inhibitors. What did we say in the last lecture? We said that for depression, major depressive disorder, we said the first line treatment is SSRIs. So some examples of these drugs include fluoxetine, fluvoxamine, paroxetine, sertraline, escitalopram. How do you want to remember all of this? Just get a good handle on it. Look at that, a bit of visual, that's the best way. They're not going to ask you to write out all these medications, right? You're going to recognize it, you're going to be golden at that. Don't worry about it. Just keep repeating. What is the mechanism of action? It inhibits the reuptake of serotonin levels. In the previous lecture, we learned the pathology of depression is serotonin levels are decreased as well as other neurotransmitters such as norepinephrine, dopamine. So we want to increase these levels. We want to increase the serotonin levels. Think about it this way. All these kids are playing in the playground. We sent all the kids out to play. All the parents send their kids out to play. Now it's 5 o'clock, time for dinner. So what do they do? The parents come out, they try to bring their kids back in. They're reuptaking them back into their houses. Now you got the cool uncle, kind of like me, who comes out and says to all the parents, hey, relax, let the kids play a little bit longer. So you see what's going on over there? The medication comes out and says to the enzymes that are bringing back the serotonin levels in and says, hey, relax, let the serotonin enjoy. So I know it's a little bit of a funny joke I said there, but what we're trying to do is keep serotonin levels in the brain longer so that they can attach to more receptors and help the person feel better. What kind of clinical uses do they have? Like depression, you also want to think about other things, general anxiety disorders, panic disorders, OCD, people suffering from bulimia, PTSD, social anxiety disorder. Then there's premature ejaculation. So why are we talking about sexual stuff? One of the side effects of SSRIs is it causes a decreased orgasm, so anorgasmia in males. So males who are suffering from PE, premature ejaculation, can use this to actually help them. So that's the connection right there. It also helps female with premenstrual dysmorphic disorder. Other side effects, of course, include GI issues like nausea, stomach upset, all that kind of stuff. SIADH, syndrome of inappropriate ADH secretion. Now, for those of you who forgot what ADH and SIADH is, not to worry. Go back, click to video number 4, endocrine video number 4, because I talk about SIADH in great detail. And the cool thing is, in that video, we mentioned that one of the causes for SIADH is SSRIs. All right? The next thing is the emergency, the psychiatric emergency. When there's way too much serotonin in your body, it can cause serotonin syndrome. How does that happen? It happens when you use SSRIs combined with other kinds of things that also increase serotonin levels. So you want to think MAOIs, you want to think SNRIs, TCAs, as well as the triptan medications. What are the triptans? We're going to talk about it properly in the neurology section, but those medications are used to help treat individuals with migraines. So a combination of anything with SSRIs essentially can increase serotonin levels. But what happens? What are the symptoms? Person starts to feel agitated. They have a hyperreflexia. You know, what else is going on? They got hyperthermia. Their temperature is increasing. The muscles are very rigid. And then they have volume contraction because they're sweating. They're losing lots and lots of fluids. So a lot of volume fluid loss. How do you treat these patients? You want to block the receptors. You want to block the receptors so that serotonin can't attach there anymore. We use a medication called cyproheptadine. That's a 5-HT. That's a serotonin receptor antagonist. For those of you studying for your boards, especially step 2, step 3, they're going to talk about management. You want to make sure that you understand that the question stem is saying that the person is also losing fluids. So what do you want to do? You want to replenish fluids, IV fluids. Third thing, you can also attach benzodiazepines. Benzodiazepines will help the patient relax that muscle rigidity that they have. What did we talk about in the last lecture? We said that SSRIs take about 4 to 8 weeks to really work on the patients. That means improve their mood, improve their energy. But the first couple of weeks, very crucial, because although it's not improving the mood much, it is improving energy. So during the first 2 weeks, you want to make sure that you want to tell the spouse, the kids, the parents, hey, watch over this person because they might have an increased risk for suicide. Now let's move on to the SNRIs, serotonin norepinephrine reuptake inhibitors. So of course, just like the name sounds, you are inhibiting the reuptake of both serotonin and norepinephrine. Some examples of some medications, you got duloxetine, you got venlafaxine, you got desvenlafaxine, you got milnacipran, okay? You can use these medications to help with what? Depression, general anxiety disorder, as well as diabetic neuropathy. What else do we got? We got venlafaxine. This venlafaxine is used for all of these things over here: social anxiety disorder, panic disorder, PTSD, and OCD. Then we got duloxetine and we got milnacipran. These are used to treat fibromyalgia. Okay, so try to keep that kind of separated, but overall you want to understand the mechanism of action, most important. And of course, one of the major side effects is, of course, increase in blood pressure, so hypertension. The third category right over here, the TCAs, this is an important category. Not so much that you have to know all the medications like inside out. Of course, you'll recognize it on a test question. You want to, of course, know the mechanism of action. It's the same thing, inhibits both the reuptake of serotonin and norepinephrine. Some examples are nortriptyline, amitriptyline, imipramine, desimipramine, clomipramine. We're going to see some specific uses of that. But what's very important are these side effects. So we'll get into that right after we discuss the uses. So what are some of the uses? Again, of course, they're helping with depression. That's one of the major things. And then we got over here imipramine. Imipramine is used for your, where do we have it? Nocturnal enuresis. We got clomipramine used for OCD. So uses are, again, depression, OCD with clomipramine, nocturnal enuresis with your imipramine. Other uses, of course, think about the head and the nerves, so migraines, peripheral neuropathies, that kind of stuff, okay? Now let's think about the side effects. The side effects are pretty intense. We want to break it down so it's easy to remember. Think about the 3 C's. What are the 3 C's? Coma, confusion, convulsions, cardiotoxicities. I said 4 C's, so I added a 4th one. Cardiotoxicities, think about arrhythmias. What are you going to do? You're going to give the patient sodium bicarbonate to prevent the arrhythmias. Another important effect on the heart, it increases the QT interval. When we start the cardio section, you're going to see a lot of reasons for why the QT interval increases. And now we already know one, tricyclic antidepressants, TCAs. Alpha blocking effects. We're going to review that in pharmacology properly, but one of the major things you will see is postural hypotension. Then you got the anticholinergic effects. Anticholinergic effects, we remember everything kind of slows down. So what's slowing down? Urinary retention, constipation, especially if it's an elderly patient, they're going to have risk for falls because they get confusion. What else? Dry mouth. They're going to have a very dry mouth, no secretions from the mouth. So of course, definitely remember that. If you see that in a question stem, think what's going to happen to an elderly person. They can get the confusion, the hallucinations, they could tip over. So anticholinergic effects, make sure you memorize that. It's the same kind of anticholinergic effects that the medication atropine would have done. So keep that in mind because we're going to make that connection as well. The next category are your MAOIs, monoamine oxidase inhibitors. Some examples are selegiline, phenelzine, isocarboxazine. What are they doing over here? They're increasing these neurotransmitters. They're called the amine neurotransmitters. So all of the ones that we need, norepinephrine, dopamine, as well as serotonin. Some uses of these, atypical depression, think of that one for sure. And then selegiline, we're going to talk about in the neuro section how it helps with Parkinson's disease. But you also see these helping with anxiety. Okay, so anxiety, Parkinson's disease, as well as atypical depression. What happens when you take too much of it? Well, the problem is it's increasing your blood pressure, especially if you combine it with tyramine-rich foods. What are they? Cheeses, pickles, that kind of stuff. So hypertensive crisis. Of course, they're contraindicated again with your SSRIs, your TCAs, St. John's wort. Why? Because again, it can cause serotonin syndrome. And if you were paying attention just 3 seconds ago, what is the treatment for serotonin syndrome? We got cyproheptadine, which is a serotonin antagonist at the receptor level. We have to replenish the fluids, especially for USMLE step 2, step 3, replenish the fluids with some IV fluids. And third thing, give some benzodiazepines to relax the muscle rigidity. Nice. Okay. What do we want to know about this? If someone is on MAOIs, monoamine oxidase inhibitors, they're not working, or for some reason you want to switch medications, you need to give it a flush out period. So if you stop it, wait about 2 weeks, and then you introduce like an SSRI, for instance, because you do not want to initiate or precipitate a serotonin syndrome. So definitely remember about a 2-week flush out period. Moving along, atypical antidepressants. So these are the ones that kind of fall around not so much in any category, but we're going to kind of call them the atypical antidepressants. The first example, bupropion. This will inhibit the reuptake of norepinephrine and dopamine. Of course, you can understand that may help someone who has depression. It's also used for smoking cessation, so you might see that in a question stem. And then the next thing is, what is this saying? It's increasing seizures, the possibility of seizures in patients who have eating disorders. So patients who have eating disorders have a lower threshold for getting a seizure. So if they're now using this medication, it might put them over the edge and they may have a seizure. So it's contraindicated in people who have eating disorders, as well as contraindicated in people who actually have seizure disorders. Okay, so keep that in mind. Mirtazapine. You want to remember the 2 side effects, increasing weight gain as well as sedation. Sedation, it might actually help someone who has insomnia. So you want to see how that medication can help another issue. But what is it? It's an alpha-2 antagonist. Trazodone, like mirtazapine, also increases sedation and causes priapism. What is that? That is a sustained erection in a male. So how do you remember that? A fun way that I once learned was, think of all these letter Z's as someone is sleeping. Zzz, zzz. And then priapism, think about the letter in the ending done, which rhymes with B-O-N-E, which is bone. And I hope you can make that connection. So priapism, bone, sustained erection in a male. And lastly, we discuss electroconvulsive therapy, ECT. So where are we using it? We're using it in major depressive disorder again, especially with, when people are not getting the benefits of those of the pharmaceuticals. So treatment-resistant depression. We also talk about it with depression with psychotic features. Okay, so depression with psychotic features, people not responsive to medications. We want to use it with people who have a high risk of suicide. If someone can't take antidepressants for some reason, some sort of contraindication, you can use ECT. And you want to also make sure, another one is if patients have used ECT in the past and they've had a favorable response. So it's another indication to why ECT can be used again. Okay, and we want to make sure this over here, it is safe in the pregnant females. It is also safe in the elderly. Are there any side effects? A few side effects. There is short-term memory loss, but not to worry. Most patients, 90% of the patients, will recover in the first few months. Usually takes no longer than 6 months. Prolactin surge. There is a bit of prolactin surge, and it's a pseudo-prolactin surge. If you guys were with us when we talked about different reasons of why prolactin levels increase, go back to that video. I'm going to paste a link below as well, so that way you can read why levels of prolactin increase. Are there any contraindications? No contraindications, no absolute contraindications. You do want to make sure that if you have a patient who is undergoing ECT, just to remove jewelry, metal, that kind of stuff from their body parts. So that's it, guys. That was it. We just talked about antidepressants in a nutshell. If you watched the first video, that's perfect. If you missed the first video, go back, check out the first video, then this video will make a lot of sense. I want to thank you guys for being here today. It was a lot of material, but it had to be a lot of material because today was the first day back to school. What's happening next? Well, before you guys come check me out again on Monday, I want to invite you guys back on Friday because we got a whole new series started for you guys. Fun Film Fridays. So on Friday, I'm releasing a film. It might be a blockbuster hit. I don't know, maybe a Grammy Award winner. You guys decide, but make sure you check it out. It's going to be a short film, so whatever you're doing, play it in between your busy day. Okay? And if you don't see me then you're going to come back on Monday for another lecture with Med School Mondays with Promo.